Okay, so in chapter 16, we're going to look at disorders of the immune response. So the first kind of class of disorders we're talking about are the hypersensitivities. And what we're saying here is that we have excessive or inappropriate activation of the immune response, where basically it's going to be much stronger than normal, or inappropriate, where you can start attacking your own body's tissues. Now, what we find then is that we technically have a hypersensitivity if your body's tissues are damaged by the immune response rather than by the antigen, or sort of the pathogen it might be trying to fight off. And so the questions we have here are things like, what allergies are you afflicted by, and what are some of the common signs and symptoms of those allergies, and how does this relate to inflammation? Well, remember, we talked about with inflammation, there's the 5 cardinal signs. We talked about how there was redness, heat, pain, swelling, and the 5th is a loss of function. So what we're really going to focus on then with the hypersensitivities is how do we get loss of function then if it's all about inflammation here? Because that's going to lead to tissue damage that's associated with the hypersensitivities, and which makes them dangerous and therefore pathogenic. And that's why we talk about it here in pathophysiology. So the first type of hypersensitivity we'll talk about is type 1. Type 1 is commonly associated with allergies, so this is like allergic reactions, and these can either be systemic or anaphylactic, and they can either be local or atopic as well. With local hypersensitivities, you're talking about seeing things like urticaria or hives, rhinitis, which is hay fever, just runny of nose. Atopic dermatitis, so essentially just itching the skin in a local area, and then bronchial asthma, where we see kind of constriction of the airways. Type 1 hypersensitivities are also associated with food allergies. So in terms of the mechanism of how these occur, what happens is we actually have these T helper cells, which are kind of already primed against a particular antigen. So you'd find then that if these T helper cells were already kind of hypersensitive to an antigen, and this antigen could be foreign, like let's say like an oil of like a tree nut, and that's why you're allergic to tree nuts, or it could be latex if you have a latex allergy. Now, essentially what happens here is that once these T helper cells are activated, they can release inflammatory cytokines, and these specific ones we have are the interleukins. So you have interleukin 4, 3, and 5 here. And these interleukins go on and they excite other leukocytes. That's what they're called, interleukins, between leukocytes. So the interleukin 4 here then excites B cells. And these B cells start to turn into plasma cells, and they turn into IgE secreting antibody factories, right? Remember we said that the IgE antibodies were the ones that were more commonly associated with allergy. And these other interleukins here can activate nearby eosinophils, which are going to lead to more long-term, later responses. But let's come back up here with the IgE secreting plasma cells. Now what happens is that these IgEs are basically picked up by mast cells. And these mast cells, in response to the IgEs, become hypersensitized. And so what happens then is that these mast cells then that are hypersensitized by the IgE can then also respond to the same antigen that these T helper cells were sensitive to earlier. And so what happens then is that these mast cells quickly degranulate. And we talked about how degranulation of mast cells was the rapid release of histamine and other inflammatory mediators. So some of the early response would be due to histamine. So we see vasodilation, a little bit of increase in vascular permeability, and maybe some damage from that, as well as smooth muscle spasm. And this is consistent with the early phases of the inflammatory response. Now, vasodilation here is what's going to increase blood flow and bring in the redness and the heat to a local area. And then remember, when vascular, like blood vessels, become more leaky, this is what's going to lead to the swelling. And then smooth muscle spasms can lead to blood clots. Now, we also get the release of cytokines, which can activate other inflammatory cells. And these mast cells can release prostaglandins and leukotrienes, which can also contribute to more of these late responses. So later on in this type of hypersensitivity here, remember it's an allergy, we can see things like mucosal edema, right? So sort of a swelling of the mucous membrane, wherever that might be. If it's the nasal cavity, you get rhinitis. It could be the gastrointestinal tract, wherever there's a mucosal membrane. We get an increase in mucus secretion, which can plug airways. It could be uncomfortable. And we can also get things like epithelial damage, which comes from that loss of function, right? Excessive inflammation. and then the infiltration of leukocytes and possibly even bronchospasms, where individuals' airways start to become more narrow. That increases resistance, which decreases flow, so that individuals can have difficulty breathing in here. And so what we find then is that the cellular mechanisms of this hypersensitivity lead to the kind of the more common symptoms and signs of what we think about in terms of allergy. So type 1 allergies are mediated by, remember, IgE, and IgE antibodies were the ones that are associated with allergies. Now they're secreted by B cells, right, the plasma cells rather, but what happens is that it's the mast cells that interact with these IgE antibodies. And this makes individuals even more sensitive to that antigen. And so on the first exposure to an allergen, what happens is you're going to have the sensitized T helper cells that then release cytokines that can activate B cells that even release IgE. And then upon repeated exposure, what happens here is that individuals who've already been exposed to this allergen in the past have our mast cells with our IgE antibodies already on them. They're hypersensitized to that allergen, and they're going to get a really rapid response because of that hypersensitivity there. And when the allergen binds to IgE, then the mast cells are going to quickly degranulate, and that's going to lead to a pretty rapid inflammatory response. So early on, the inflammatory mediators that are involved would include things like histamine. We get other cytokines that are released, as well as prostaglandins and leukotrienes that can lead to sort of the secondary responses, like the mucosal edema, mucus production, that kind of stuff. Now the question here says, true or false, when mast cells degranulate, histamine is released. And we just talked about how that's true, right? Histamine is one of the first chemical mediators released during the inflammatory response. And mast cell stabilizers, things that are used to treat asthma, basically are antihistamines, right? They prevent histamine from being released. And we can use antihistamines to treat allergies, not cure them, but treat them, because this is going to help to diminish the signs and symptoms of the allergic reaction. And the way these work is they compete with histamine for different receptor sites, which kind of dampens down the inflammatory response. So an example here is anaphylaxis, right? So anaphylaxis would be more of like the systemic response to an allergen. And this is where we have so many inflammatory mediators that are released as a consequence of this type 1 hypersensitivity that it can lead to massive vasodilation, right? We're talking about not in a local area, but histamine, acetylcholine, kinins, leukotrienes, and prostaglandins, they all cause vasodilation. But what if these inflammatory mediators go systemic? Well, if they end up in your bloodstream and you get vasodilation all over, then what that's going to do is it's going to limit blood flow. You're going to decrease resistance, and it's also going to decrease your blood pressure. And so we're talking about how individuals can begin to go into shock from anaphylaxis because their blood pressure can be so low that blood stops flowing and they can't supply nutrients to their body's tissues. Now, many of these also cause bronchoconstriction by acting on the smooth muscle of your airways. So if your airways constrict, we're going to see that as limited airflow as well. Because of that increase in resistance, you're going to get decreased flow. And then people are going to have sort of respiratory symptoms of this as well. So anaphylaxis is this interesting combination of people who have extremely low blood pressure and difficulty breathing. And together it can be life-threatening. Now, we have a scenario here. It says a woman had anaphylactic reaction, and you're trying to explain the mechanism to her husband. He says he can't see what you mean. Or, I'm sorry, he can see what you mean, but it does not make sense because his wife's experience was different. Her heart was pounding, she was terrified, and her eyes were dilated, so pupils were dilated, and she was shaking. So the question here is, how could anaphylaxis cause these signs and symptoms? Well, it's not the anaphylaxis itself that's causing these particular signs and symptoms, but rather if someone's self-monitoring their own internal body state, like anaphylaxis can be pretty terrifying. With that decrease in blood pressure, they can become dizzy, disoriented, and when their airways start to constrict through bronchoconstriction, they have difficulty breathing, and that in itself is terrifying, right? Like it brings terror, and that's going to be a sympathetic response. We know that the sympathetic nervous system acts to increase heart rate, causes pupillary dilation, and the shaking can just be from excessive muscle activity. So what we find then is that anaphylaxis isn't causing these directly, but rather leading to a psychological phenomenon where the individual gets scared and they have these kind of these kind of signs and symptoms. Now with the type 2 hypersensitivity, it's similar to type 1 hypersensitivity in the sense that it's antibody mediated, but what's happening here is that it's not an involvement of IgE, rather it's an involvement with the IgG and IgM antibodies. Remember, IgM is the large one. It's made of 5 different antibodies. They're all strung together into a kind of circular chain. But IgG can be cut from IgM, so they're similar in that regard. Now, what happens here in this particular type of hypersensitivity is we have autoantibodies. So these antibodies here can bind to antigens on cell surfaces, right? We're saying that these antibodies can bind to red blood cells, white blood cells, and this can be associated with transfusion reactions or different drug reactions. Now, when these antibodies bind to your own body's tissues, it can cause a variety of diseases. Like there's certain types of epilepsy that are caused by type 2 hypersensitivity, where your own antibodies can start to excite neurons in your brain, and it leads to firestorms of electrical activity. Now, these antibodies can also bind to things like TSH receptors in your thyroid, which can lead to excessive thyroid hormone. Or in myasthenia gravis, these antibodies can bind to the nicotinic receptors at skeletal muscle, and they can block those receptors, which then actually leads to muscular weakness. Now, in terms of the mechanism of type 2 hypersensitivities, what's going on here, remember, it's antibody mediated, and we're talking about IgGs and IgMs. Now, this can come about if essentially, we have phagocytes that might recognize a particular antigen and they phagocytose that antigen-antibody complex. But remember, it's autoantibody. And it can also occur if antibodies can recognize antigens on a cell surface here, and that can lead to activation of complement, which can lead to inflammation and damage to these cells. It can also occur where free antibodies actually interact with different receptors. So with C here, this is an interesting phenomenon where autoantibodies here, they're IgGs that bind to TSH receptors, but instead of blocking them, they activate them, because this antibody acts like thyroid stimulating hormone. So when the antibody binds to the receptor, it actually leads to a stimulation of these thyroid cells, the follicular cells of the thyroid, which leads to an increase in thyroid hormone production. So this is actually a type of hyperthyroidism that's caused by a type 2 hypersensitivity. It's also possible too for these antibodies to bind and block receptors. So in the case of myasthenia gravis, what happens here is these antibodies bind to the nicotinic receptors on skeletal muscle, and they block the binding site for acetylcholine, so that skeletal muscle ends up getting paralyzed as a result. So they don't activate the receptors, they're actually blocking it. Now, with the scenario here, we say that a woman is Rh negative and her husband is Rh positive. Remember, Rh factor is rhesus factor. That's going to give you the negative or positive sign in your blood type. And she's pregnant with their first child. The doctor prescribed Rogam, but the woman's confused. She says that she doesn't want to take any drugs while she's pregnant, and the doctor told her that her first child was not as much of a risk for Rh disease. So Rh disease would be erythroplastosis fetalis, and it's a condition where you can have an Rh positive fetus within an Rh negative mother. So what happens here is that if the mother's immune system recognizes Rh factor on fetal blood cells, she can begin to produce antibodies against Rh. So she'll make anti-Rh antibodies, and those antibodies can cross the placenta and start to attack basically the fetus's blood cells. And so this can become a problem. It can be life-threatening for the fetus. So what happens then is there's a drug called Rogam, and it's an antibody against anti-Rh antibodies. So you actually can block antibodies from being able to cross the placenta by using this drug. Now, it's not a drug in the traditional sense. It's actually antibodies that are made in a lab. But this is useful to take if you're thinking about an individual who might be at risk of producing antibodies against their fetus's antigens. Now, the question here says, why cannot she wait to take Rogam if she gets pregnant again and really needs it? Well, the issue here then is, upon subsequent pregnancies, she's more and more likely to produce anti-Rh antibodies if she keeps having Rh positive fetuses. And so what's going to happen then is she's more and more likely to produce those antibodies, which can cross the placenta and basically, attack the fetus's red blood cells. Now the problem though is that Rogam is an antibody. Now, if you take this too much, you can start to make antibodies against RhoGAM because that's a foreign antibody. And so, if you take too much of this, it can actually lead to, basically immunity against the drug, which is kind of interesting. Now, this question here says, why is the blood considered a universal donor? Why is O blood considered a universal donor? Now, the reason being is, we have different questions here. So it says it has both A and B antigens in the red blood cell, has neither an A or B on the red blood cell, has no antibodies in plasma, or it has A or B antibodies in plasma. So the answer here is the fact that it does not have A or B antigens on the red blood cell. Remember, type O isn't an antigen in the sense that it can stimulate an immune response. O refers to the lack of A or B. Right? So if you're type O blood, then you don't have A or B antigens on the red blood cell surface, which is why they're considered a universal donor in that sense, because there's not any antigens or A or B antigens for the recipient's immune system to respond to. So, remember, antigens are components that elicit an immune response, like a type 2 hypersensitivity reaction. So individuals who might be exposed to a foreign antigen can begin to produce antibodies against that antigen. Now, because type O blood doesn't have A or B antigens, anyone can receive it because there's nothing to stimulate the production of antibodies that attack that blood, right? So the fact that type O blood has both A and B antibodies doesn't really generate an antigen-antibody response. You might get type O blood. An individual might actually already have preformed anti-A or anti-B antibodies, but there's not enough of those to cause a problem in the recipient's body. So with a type 3 hypersensitivity, what's interesting here is that it's also similar to type 1 and 2 because it's antibody mediated, but this is a delayed hypersensitivity because it's where antibodies bind to antigens, but they're inefficiently removed from the body. So you get these circulating immune complexes that can deposit on the walls of your blood vessels, and they can lead to damage in blood vessels. And systemically, this can lead to things like autoimmune vasculitis, glomerulonephritis, serum sickness. And serum sickness is associated with things like antibiotics, certain foods, and venoms. But it's a delayed hypersensitivity. And if it's local, we call it Arthus reaction. So what we see here then is we have antibodies that can actually bind with antigens. And these antigens are, they can essentially be just a foreign antigen. And when these antibodies bind, they can produce these immune complexes that, if they're not removed, they can actually deposit on blood vessel walls, which can unfortunately lead to the activation of complement. We talked about how complement can attract inflammatory cells, which can lead to excessive inflammation. And with a loss of function, you can actually get damage to the nearby cellular structure. And so, we're seeing that a type 3 hypersensitivity is going to lead to more like a vascular type of disruption here because of these antibody-antigen complexes build up in the blood vessels. And they're particularly going to affect very vascularized tissues, like your kidneys, because your kidneys receive a tremendous amount of blood flow. This is why it's going to be associated with the glomerular nephropathies or glomerulonephritis, because this is going to damage the capillaries of your kidney glomeruli, which can lead to renal failure. So the key here then is actually helping to effectively remove these antigen-antibody complexes, or just not being exposed to the antigens to begin with. So the question here says, true or false? Administration of certain antibiotics can result in a type 3 hypersensitivity reaction. And the answer is true. In fact, we just saw in the last slide how the antigen could be the stimulating factor for an antibody to bind, and that could lead to the type 3 hypersensitivity. Now, this is actually a side effect associated with antibiotic administration, like penicillin. Penicillin is an antigen, right? It's a molecule that's produced by a fungus, right? Penicillium. And this fungus is producing this as an antibiotic, right? Well, we can use this fungus molecule to fight microbes in our own bodies, but it's still a foreign molecule. And so what can happen then is we can begin to generate antibodies against this foreign molecule, and that can lead to what we call serum sickness, which is a type 3 hypersensitivity reaction where people are, they say allergic to penicillin. What they mean then is that antibody-antigen complexes can build up where penicillin and your own antibodies can bind. They can actually deposit in blood vessels, and that can lead to damage to a lot of different tissues. So a type 4 hypersensitivity is different than the first three. This one does not have anything to do with antibodies. Rather, this is cell-mediated. This is where T cells are hypersensitized, and what can happen here then is cytotoxic T cells can actually be damaged, and this is also associated with certain viral reactions. We consider this also a delayed hypersensitivity, and it can be associated with things like macrophages and T helper cells, and it might be precipitated by things like the tuberculin test, where they're looking for tuberculosis. It can also be associated with contact dermatitis and hypersensitivity pneumonitis. Now, in terms of this mechanism, what's going on here is that we have antigen-presenting cells like macrophages that can engulf a foreign antigen, right? Now, once they present this antigen to the CD4 cells, the T helper cells, they can essentially cause excitation of cytotoxic T cells, which can damage nearby tissues. Now, the problem here then is that you get both direct cell toxicity, like these could be antigens of your own body, by the way. So this can be like a form of autoimmunity, but can also lead to delayed reactions too, where these primed CD4 cells, these T helper cells, could later on release cytokines that lead to inflammation and a loss of function as a result, and that could be delayed. So remember, type 4 hypersensitivity, just think about how these macrophages are presenting antigens to like hypersensitive T helper cells, and that's leading to an excessive kind of T cell mediated response here with the type 4 hypersensitivity. Now, like with organ graft rejection, these are also hypersensitivities, and they can be hyperacute, acute, or chronic. If it's a hyperacute sensitivity, what we're saying then is that circulating antibodies just immediately react with the graft. You might get a graft of a solid organ, and if there's already antibodies that can attach to those antigens of the graft, it's hyperacute because it's going to occur immediately because they're already preformed antibodies. Acute could be sort of a several day delay or week delay, where eventually you get the generation of T cells that can activate B cells, which can produce antibodies against the graft. But it's going to take much longer than hyperacute. And then with this chronic type of hypersensitivity for graft rejection, we say that over time, blood vessels in the graft are gradually damaged. And this could result from like a type 3 hypersensitivity where, antigens that are associated with the new organ could bind with antibodies in the host, and those can deposit within blood vessels, leading to damage to the vasculature and kind of slow decline of the organ over time. Now, with hematopoietic cell rejection, we're talking about bone marrow transplants, right? So what happens here is that the T cells that come from the bone marrow can react with a transplant. And this can lead to what we call graft versus host disease. And this occurs in individuals who might need to have a bone marrow transplant, where if they had like leukemia or lymphoma and their bone marrow was wiped out through radiation treatments, if they get basically a bone marrow transplant, they're receiving an entire new stem cell set from potentially someone else. Now, the problem here then is that the transplant needs a functional immune component, right? So it could get this from somebody else. But the host tissues can have antigens that are foreign to the donor tissue, right? So the host immunity can be compromised as a result. And essentially what's happening here is that individuals can begin to produce new immune cells that actually are foreign, not of their own body, and they can start to attack the host cells and vice versa. Your own immune cells that maybe are still existent there can begin to attack the new bone marrow that was transplanted. So that's called graft versus host disease. Now, they can typically check for this, right? You're looking for MHC compatibility. Like if someone has very similar MHC to you, you're less likely to get this graft versus host disease because you're going to say that their immune cells can seem to recognize your cells as potentially self if the MHC is identical or at least similar, right? Now, they can test for MHC compatibility through genetics, right? And but also you can just test for this in sort of lab simulated settings where you just mix cells and see if they react. Now, with graft versus host disease, there's some interesting phenomena here. And we see that men who get bone marrow from women are more prone to graft versus host disease than men who get bone marrow from other men. And so it's also suggested that that women who've had more children are more likely to have graft versus host disease as well. And so the question here is, why might this be the case? Well, it seems to be that there probably is a genetic component, right? And that can relate to gender or sex. And what we're saying here then is that if men get bone marrow from women, then they're more likely to have different MHC, so they're more likely to have graft versus host disease than if men get bone marrow from other men. And the component here where if a woman has lots of children, right, like a high parity, she's at a higher risk for graft versus host disease. Well, the children that she's harbored in the past would have foreign antigens. And so what we're saying here then is that it's possible that her T cells are already sort of hypersensitive from previous pregnancies. And if she gets a bone marrow transplant, they're going to be even more hypersensitive to the foreign MHC and other foreign antigens. And that's more likely to cause graft versus host disease because she's had prior exposure to foreign tissues. And that's going to put you at a greater risk for responding to foreign tissues. So autoimmune diseases can include, but aren't limited to, hypersensitivities. So what we're saying then is that autoimmune disease is that there's a destruction of the self-tolerance. We talked about earlier how B cells and T cells, when they're maturing, they're checked for self-tolerance, and essentially we want to make sure that our own immune cells don't respond to your own body's antigens. Now, if this self-tolerance breaks down, then the immune system can attack self-antigens and therefore destroy body tissues. And if you think about, well, how many autoimmune diseases are there? Well, I mean, it's virtually the same number of as you have antigens in your body. I mean, like really any tissue of your body could be subject to autoimmunity. So the question here is true or false? Patients who suffer from autoimmune diseases have hypoactive immune systems. And the answer is false, right? We're saying that autoimmune disease is a consequence of hyperactive immune systems, right? So we're saying that the immune system is too active, it's overly active, and it starts attacking self-antigens and destroys its own body tissues. And what's fascinating here is that if we can look at autoimmunity as a hyperactivity of your immune system, then we can actually treat autoimmunity by kind of making sure that our immune system isn't underactive, right? If you can ensure that your immune system is like fighting off different microbes and it has less time to attack your own body's tissues, that can decrease the signs and symptoms of autoimmune disease. In fact, you see this with a condition called helminthic therapy, right? So helminth is a worm, right? And so helminthic therapy is the idea that you can actually give someone a parasitic worm if they have autoimmune disease, because then their immune system is going to actually kind of target that parasitic worm rather than fighting off your own body's tissues. And so being infected with a parasite actually can diminish the signs and symptoms of autoimmune disease. And there's research labs that are working on this right now to isolate antigens that can potentially simulate what it's like to be infected with a parasite. That way you can treat autoimmunity in that way. So immunodeficiency is the opposite of what we talked about, right? So it's not hypersensitivity, it's not autoimmunity. We're saying that immunodeficiencies could come about from an underactive immune system. And these can be associated with B cells, T cells. It could be a combination of both, like with the severe combined immunodeficiencies or SCID. So an example of where this occurs was the bubble boy, right? If you remember that case. And SCID, or severe combined immunodeficiency, is where you actually have inefficient or sort of underproduction of both B cells and T cells, and so that they don't have an adaptive immune response. They're going to rely on their innate immune response, which really isn't good enough to fight off just the whole gambit of infection. And so these individuals are severely immunocompromised. An example of like a T cell deficiency could be with thymic hypoplasia, where individuals can actually just not develop a thymus very well, so they don't actually develop T cells, and so that can lead to deficiencies later on in life. And they have Wiskott-Aldrich syndrome as well, which is actually a heritable condition, and it's X-linked recessive, where individuals essentially inherit a defective immune system, like they don't make leukocytes that function properly. And it can also be acquired too. There's acquired immunodeficiency, which can come from malnutrition, like you need certain nutrients to support your immune system. There are immunosuppressant drugs. Radiation can lead to immunodeficiency, and even certain viruses. When we talk about like HIV, that can lead to AIDS, which is a form of acquired immunodeficiency. So with human immunodeficiency virus, or HIV, it can be transmitted through a variety of ways. It really has got to come from like direct contact, whether that's sexual contact, breast milk, or blood-to-blood contact. Otherwise, it's not airborne. It's not really transmitted through saliva, and it wouldn't be transmitted through skin contact either, unless you both had open wounds. So that would be more of a blood-to-blood contact. And so where an individual might encounter blood-to-blood contact would be things like using contaminated needles, having transfusions, where there might be HIV in the transfused blood, and possibly even during pregnancy or birth, where HIV can be transmitted across the placenta, or it could be transmitted during labor, just because of like ruptured tissues and that kind of stuff. So HIV infects CD4 positive cells, right? And so you might wonder, well, what type of cells have CD4 receptors? Well, we already talked about the T helper cells, right? So your T helper cells are CD4 positive, which means that HIV will specifically infect T helper cells. And that's not good, because those are the ones that are going to excite other immune cells by releasing cytokines. Dendritic cells are also CD4 positive. That's also not good, because those are the ones that crawl around in your epithelial tissues. And that would be the first cell that's going to be infected by HIV, because if you have a wound or something, and HIV encounters one of those dendritic cells, well, it can infect that dendritic cell. But dendritic cells are mobile. They can move around your body. They can move from skin to lymph nodes and that kind of stuff. And so they can bring the HIV virus like deeper in the body, where it can then get closer to like T helper cells. And the other type of CD4 positive cell in your body are neurons, right? Nervous cells are CD4 positive. So one of the interesting phenomena that happens with HIV infection is that people can get AIDS dementia, where over time they actually get cognitive decline that's caused by HIV infection. Now, what's fascinating too is that HIV is an RNA virus, right? So it's in the virion, it uses RNA as its genome, but it packages its own what we call reverse transcriptase. And what reverse transcriptase does is it converts HIV's RNA genome into a DNA strand, and that can be inserted into the host cell's genome using an enzyme called integrase. Now, it's done randomly, like there's not like a specific point that the HIV genome is inserted into the host cell, and that's a problem because that can actually lead to proto-oncogene formation. So you actually can convert proto-oncogenes to oncogenes if they're inserted in the wrong place. So if we look at the structure of an HIV virion here, right, this is one infectious particle, and so we see that it's actually an enveloped virus. So it's got a lipid bilayer. This lipid bilayer has lots of glycoprotein spikes like GP120 and GP41. These are both pharmacological targets because we can have binding inhibitors where you can block GP120 and GP41 using different drugs. And if you can block these glycoprotein spikes, then HIV can't bind with a host cell. So we actually have fusion inhibitors. Now, HIV is a nucleocapsid as well, and within this you're going to find your RNA genome, and it's encased in this nice little protein sheath. But what's fascinating about HIV, it actually packages some of its own enzymes. Like it packages an enzyme called reverse transcriptase, it packages an enzyme called integrase, and another one called protease. Now remember, reverse transcriptase is the one that converts RNA into DNA. Integrase is what actually helps to insert the DNA HIV genome copy into the host cell genome, and then proteases are involved with basically cutting up a viral polyprotein into lots of individual polypeptides, which are the viral particles, or the viral proteins, like other enzymes. So if we look at the viral life cycle here, we see that it first starts with fusion of HIV virion to the host cell membrane. Now remember, it actually binds with the CD4 receptor. That's how it only infects CD4 positive cells, is it uses that receptor to grab onto host cells and then get in. Now, when it binds, it fuses, and it enters the cell then through fusion. And at that point, what happens is the nucleocapsid enters, it breaks down, and you end up with HIV RNA genome with reverse transcriptase, integrase, and protease. They're all there at that point. Now, reverse transcriptase converts the RNA genome into DNA. These DNA strands can actually be inserted into the host cell genome through integrase. And at that point, then we're saying is that the HIV genes will now be read and expressed as if they're the host cell genes. And so the host cell then just starts making viral polypeptides as a result. Like this would be viral mRNA. And this mRNA is going to carry information about how to make HIV proteins. That's going to go to ribosomes, which make viral polyprotein, and then protease, which is what one of the enzymes that HIV packages, can cut up this polyprotein into individual, basically viral proteins that can get packaged into new virions, and those can bud out of the host cell. Now, the reason why we want to understand the life cycle of HIV is that all of these steps are potential pharmacological targets, right? Like we have drugs that can block GP120 and GP41. That way it can block the binding of HIV. We actually have reverse transcriptase inhibitors. We have integrase inhibitors. We have protease inhibitors. And the cocktail of drugs that an individual would take then would actually target all of these aspects of the viral life cycle. Now, the problem, though, is that we don't have a cure for HIV because, for one, it hides out in host cell DNA, and you can't find it there, right, unless it's actually actively shedding virus. And two, HIV is an RNA virus. It has a high mutation rate, so it mutates pretty quickly. In fact, it can mutate within a host's body. So the clinical course of HIV would be things like, so the primary phase here is that we have signs of systemic infection. So you're going to get sort of the fever and sweating, that kind of stuff. And when we talk about seroconversion, we're saying that we can measure HIV RNA in someone's bloodstream 1 to 6 months later, right? And so they say, to be safe, they say about at 4 months, you might have seroconverted. But it takes time to be able to measure it. So you couldn't have like an exposure event and then get tested the next day, and they can't tell you for certain if you actually have HIV at that point. It takes a while for the viral particles to replicate to the point where we can actually measure them in the bloodstream. Now, at this point, the immune system can attack HIV virions. It's still a foreign antigen, and these things can be attacked by your immune system. And if suppressed enough, the virus can go into latency. And latency could be, decades. And latency can occur where the virus is replicating, but, not strongly. So the viral count could be very, very low. But the T helper cell count can gradually fall over time as a consequence of just damage to T helper cells. Now, decades later, this can actually lead to AIDS, which is acquired immunodeficiency syndrome. And this is a clinical definition where we say that individuals have less than 200 T helper cells per milliliter. At that point, then we say that it's AIDS. And this is the defining illness, sort of that clinical feature there. Now, what this is going to occur with then is a lot of signs and symptoms that would correlate with a lack of T helper cells. And so some of the AIDS-associated illnesses would be things like opportunistic infections. They're going to get a lot of really odd infections that you wouldn't find in a normal, healthy individual. Odd respiratory infections, especially fungi and bacteria that typically don't affect normal people, or healthy people rather. Gastrointestinal infections that are opportunistic. You might get a lot of things like C. diff, which is part of your normal flora, but it's usually kept down in smaller quantities by your immune system. You can get nervous system infections too, like meningitis and encephalitis that are associated with AIDS. Now, what's also kind of fascinating too is that AIDS is associated with different malignancies. And the reason for this is that HIV, when it integrates into the host cell genome, it does it randomly. Like there's not like a place that it inserts itself into. This occurs randomly. Sometimes this kills the host cell. Sometimes it does nothing to the host cell. Other times it can cause mutations, and those mutations can lead to malignancies. And so there's different types of leukemias that are actually caused by HIV. We also get different malignancies too, like Kaposi sarcoma, which is actually a skin type of malignancy, and they get these kind of large bluish areas in the skin. It can lead to wasting, where individuals just have wasting of their body from just chronic stress, as well as some metabolic disorders. Now, in the gastrointestinal system, I should also mention too, is that people are at a higher risk for candidiasis. So they're more likely to get candida infections, or basically yeast infections of like the oral mucosa, that kind of stuff. Now, the scenario here says a man as HIV positive. And he says this is nonsense because the test doesn't measure whether he's sick or not. In fact, it means his immune system is working. Is he right? Well, if we say that the test tells him he's HIV positive, what they're measuring for are not anti-HIV antibodies. You can find that. All that's going to tell you is if you've ever been exposed to HIV. The more definitive tests are actually going to be PCR, where you're looking for HIV viral transcripts. And what PCR does is it essentially amplifies DNA, and you use this using a primer. So if you take a sample of someone's blood, you can kind of search to see if they have HIV, essentially genetic code there. And if it's present, then that suggests then that they have an infection. Now, it's not true that if you test positive for HIV, then that means your immune system is working, because they're measuring for essentially the viral genetic information, not antibodies itself. So that wouldn't be a correct statement. So the other question here says, one AIDS drug is a protease inhibitor, and so which step in the viral life cycle would be targeted by this protease inhibitor? Would it be binding to the T cell, conversion of RNA to DNA, integration to become a provirus, or formation of viral proteins? Well, we talked about how protease inhibitors would target basically viral protease, which cleaves the viral polypeptide into separate pieces, right? Now, what's kind of weird then is that HIV transcript is one large mRNA, and so that's going to contain all of the proteins that HIV requires. So that the mRNA gets read by the host cell ribosome. That's created into a long chain of viral polypeptide, but the viral protease is what cuts the viral polypeptide into lots of separate pieces, and each one is its own individual and separate viral protein. Now, if you can block viral protease, then you can prevent this from actually being able to make functional viral proteins. And at that point, then you can't make new infectious particles. Now, it wouldn't cure HIV, but it could definitely prevent or limit the spread of these infectious particles. And so you can actually knock someone's HIV into sort of remission. And that way their T cell count can get back up, and their HIV virion count could actually be undetectable at that point, depending on how well these drugs are working.